Hello, everybody. Welcome to this webinar. My name is Natasha Bolaños. I am here on behalf of Lymphoma Coalition. We are a global network of 82 patient organizations from 52 countries working on the lymphoma space. And I am pleased to introduce this webinar that was organized in collaboration with the Cutaneous Lymphoma Foundation, Eurordis from Lymphome Espoir, and EuroBloodNet. Before starting the meeting, some housekeeping rules. Today's webinar is being recorded and will be available through EuroBloodNet YouTube channel. Please, we appreciate if you could switch off your video cameras and mute your micros to ensure the audience focus only on the speaker during the presentations. For questions and answers, you can type your question in the chat box at any moment during the session, but time will be allocated at the end for the speakers to address your questions. And now let's set the scene. Cutaneous T-cell lymphomas are rare diseases with an annual incidence of around 10 per million persons. Please, Susan, correct me if I'm wrong. Mycosis fungoides and Sézary syndrome are the most common types of cutaneous T-cell lymphomas and account for around 50%, depending on the literature you review, of all primary cutaneous lymphomas. Today, I'm delighted to introduce the speakers that join this webinar. Professor Martin Vermeer is head of the Department of Dermatology of the Leiden University Medical Center. He has received grants from the Dutch Health Council and leads transnational research of the ERTC Cutaneous Lymphoma Working Group and the Cutaneous Lymphoma International Consortium. He has a long story of research and publications in this area, including clinical practice, and we appreciate that he could be being the lecturer today. We will have a patient with cutaneous lymphoma, Miek de Leeuw. She has been a volunteer at Hematon since 2018 and for the Skin Lymphoma Foundation and the Platform for Rare Cancers. She acts as a linking pin between the mentioned organizations after having living a 10 years story of misdiagnosed skin conditions and challenges. She will share her story and her journey with us, and we are very pleased to listen directly from her words and her experience, because these really make us understand how challenging this condition can be. She has now, of course, developed very much knowledge about her condition, and I do not have any doubt about her capacities to transmit this experience and knowledge, knowing her background as a principal in a high school for children from 12 to 18 years. The moderator today will be Susan Thornton. She's the current CEO of the Cutaneous Lymphoma Foundation, and she's also a board member at the Lymphoma Coalition. Susan is also a patient, and she has been living with cutaneous lymphoma for close to 30 years, I think. So she has intimate knowledge of what it's like to live with this rare, incurable disease that requires permanent treatment. Susan has spent also 28 years working in the healthcare information technology field in various consulting, sales, marketing positions, different leadership positions as well. And outside of her professional endeavors, she is always supporting and very active, cooperating with many nonprofit organizations, including all the organizations that cooperate to put this webinar in place. So Susan, the floor is yours.
Thank you, Natasha, for all that beautiful introduction. And I will just add my thanks and gratitude to Professor Vermeer and to Miki for joining us today. I think this is going to be a really wonderful program and encourage you to write your questions in the chat so we can get them answered, and look forward to an open dialogue. And as we move forward through the presentation, it's really an honor and a privilege to be part of this esteemed faculty today, and really grateful to both of you for taking the time and sharing your experiences, and Professor Vermeer sharing your knowledge and deep wisdom about cutaneous lymphoma from the clinical perspective. So I will now turn the floor over to Professor Vermeer to take us through the clinical presentation. Off to you.
Thank you, Susan, for a very, very nice introduction. Indeed, I'll give a first sort of clinical introduction to cutaneous lymphomas, focusing on mycosis fungoides and Sézary syndrome. And after that, we will hear more a personal story from Mieke, of course. And but let's start first with some background slides. And now I have to share the right screen. And if everything went well, you now see, as I just mentioned, I think the most impressive introductory slide that I've ever made, because it's not only mentions the LUMC where I'm working, but also all the other organizations, including the Stichting Huid Lymphome, Lymphoma Coalition, and Cutaneous Lymphoma Foundation, that all make up this wonderful collaborative effort, which is really collaborative, going over the borders of different countries, bringing together different type of physicians, but also bringing together physicians and patients, which I think is a fantastic development. So this is the introductory slide. And now let's go to the next. Yeah, next. So cutaneous lymphomas, where do we start? It's a rare group of malignancy. So it's a cancer, and it develops from lymphocytes. These are T cells, also called T cells, that present with their first lesions in your skin. It's important to realize that there are different types of cutaneous lymphoma. So it's not, this is an all-encompassing term, but within cutaneous lymphoma, there are different diagnoses. And these different diseases have a different prognosis and therefore a different treatment approach. It makes it a little bit complicated because there are few, and these few lymphomas are different. And therefore you need a correct diagnosis, and diagnosis and treatment for cutaneous lymphomas is for these reasons needs specific expertise and is often organized in specific centers, because these centers know how to identify, how to recognize which type of cutaneous lymphoma we are dealing with, and then they are knowledgeable or should know what the type of treatment they should use. To make a correct diagnosis, to take a very good look at the skin, what is the clinical picture, but also what do we see under the microscope, so what is the skin histology, is essential to make a correct diagnosis. So nearly all patients with cutaneous lymphoma tell me the same story, that people looked at their skin, they weren't sure what it was, they've taken a biopsy. Sometimes this biopsy does not tell immediately what kind of disease we are dealing with, and some patients need repetitive biopsy or multiple biopsies before a correct diagnosis can be made. Focusing on mycosis fungoides, which is the most common type of cutaneous lymphoma, the large majority of patients will start with eczematous skin lesions, so with redness and some scaling. The technical term for this is patches and plaques. And for instance, this is a patient that has some slightly infiltrated patches on the buttocks, which is a very characteristic presentation for this disease. If you would take out a biopsy, if you would take out a small piece of skin, it's still very difficult to recognize this disease, because this is the histological picture. This is outside, this is inside the skin. This is the epidermis, so the outer layer, and this is the dermis, the inner layer. And in this epidermis, these cells, these dark cells with some halo around them that are sometimes like a string of pearls located in between the basal keratinocytes, these are your tumor cells. But you can imagine it's very easy to miss this picture if you are not an expert. And the large majority of patients, they will have this type of disease for the rest of their life. Some patients, their progression will develop, and then within these axillematous lesions, larger, more fleshy nodules or tumors will develop. And now if you take a biopsy from this lesion, it's much easier to make a diagnosis because this picture is filled. All these cells are neoplastic cells. These are all tumor cells. Fortunately, development of extracutaneous lesions, so tumor cells outside the skin, and development of nodules in lymph nodes or in other organs only develops in a minority of patients. And this sort of summarizes what I just told you. So the large majority of patients starts with these type of lesions, T1 it's called, this is the tumor staging system, and only 4% will progress to this stage. And both stages still have pretty good 10-year survival. So in fact, the 10-year disease-specific survival for these patients is the same as in the general population. In this population that have patches and more infiltrated plaques covering more than 10% of the skin, the 10-year survival is slightly less. It goes down to 83%. Around a quarter of these patients will progress to the tumor stage disease, and in tumor stage disease, the 10-year disease-specific survival drops to 40%. So there's a stage-adjusted prognosis. If you make a diagnosis in mycosis fungoides, now that you know this, you can imagine it's very important to make a very careful inspection of the skin, so you know how many patches and plaques are there, and if tumors have developed. And in addition to that, you need skin histology. So skin biopsy is absolutely something that you need. Additional staging, so CT scans or blood analysis, is only indicated if patients have additional symptoms, for instance, pain in their stomach or things like that. In the treatment that we give to patients, because the tumor cells are located in the skin and not in other organs, we can use so-called skin-directed therapies. The preferred treatment is the treatment that is very effective in your skin and leaves your other organs without any toxicities. Now, the type of skin-directed therapy that you use is always adjusted to the type of skin lesion that you have. So a patch or plaque will mostly respond to the use of local steroids or light therapy, but a tumor will not. So in a tumor you need, for instance, radiotherapy. If patients do develop nodal or visceral involvement, so tumor cells can be found now in lymph nodes or in the liver or the lungs or other organs, then, and only then, do we need additional systemic chemotherapy. And at present, we are discussing a lot with the hematologist what is the best type of chemotherapy and how can we combine it with a stem cell transplantation. It's a rather complicated picture that I showed you, and the multiple drugs are around that we can use in different stages, and how to use them in the most effective way is a sort of art in itself. Fortunately, a number of colleagues have come together and have written down guidelines that can help the clinicians to choose the most effective and the best treatment. And these guidelines have been made with the people from the EORTC that I'm also part of, by the British Association of Dermatologists, and also by the ESMO clinical practice guidelines. And also in America by the NCCN, so the National Comprehensive Cancer Networks. These guidelines also provide these type of pictures. So now again, you see the different tumor stages. So these are patches and plaques in a very limited area. This is a more extensive area, and these are the development of tumors. And as you can see, some treatments like the topical steroids are positioned very early in disease, and some treatments like systemic bexarotene is in later stages of disease. And this is an example from the ESMO guidelines that uses the same principle. So again, first you look at the stage, so the type of skin lesions that a patient has, and then we find here different treatments that can be used in that stage. And it's always, or should be, I think, in a dialogue between the physician and the patient that you choose one of the treatments that fits best with the stage of disease, but also fits best with the life of the patient. This is just an example. This is again a patient with limited mycosis fungoides. In this patient, for instance, local steroids would be a very good option. Phototherapy, PUVA, would be an option if it's more extensive, and local chemotherapy with chloromethin, so the what's it called, chloromethin, that can be used as well. For tumors, you typically use radiotherapy, and one of the important, I think, one of the important developments in the last couple of years is that we have learned that we can use radiotherapy in a relative low dose. So 8 grays or just twice radiations will be sufficient to clear these type of tumors. And in patients with very extensive skin lesions, we can even irradiate the whole skin. Now, in a small proportion of patients, fortunately, only a small proportion will develop nodal or visceral disease. And in these patients, traditionally, were treated with intensive chemotherapy. Unfortunately, this chemotherapy has a lot of side effects and it cannot cure disease. So if after you stop this treatment, the disease will come back again. And we are now really trying to combine these type of treatments with more advanced stem cell transplantation protocols, and more chemotherapy is also replaced by different immunomodulating therapies. This is an overview of the cytotoxic drugs that are relatively new. HDAC inhibitors, a whole different disease drug class, but I think this is the most important and the most interesting development. These are antibodies. These are antibodies against CD30 and CCR4. And CD30 and CCR4 are proteins that are on the membrane of your tumor cells. And with antibodies that are directed against these proteins that are present on your tumor cells, it helps your immune system to destroy the tumor cells. And this, combined with new allogenic stem cell transplantations, is a very, well, I would say, hopeful development for patients with much more advanced disease. Then shortly, something about Sézary syndrome. You could say Sézary syndrome in a way is different from mycosis fungoides in that from the beginning of the disease, the tumor cells can be found in the blood, in the skin, and in lymph nodes. So from the moment the diagnosis Sézary syndrome is made, you have to think about tumor cells that are present in the blood, skin, and lymph nodes. Because these tumor cells are in these so-called different tissue compartments, patient will present with an erythroderma, so redness of the skin from head to toe, that is often very itchy, and swollen lymph nodes, because the tumor cells are present in the lymph nodes as well. And these atypical cells can be seen in your skin histology again, so you need to take a skin biopsy. They can be found in blood, and these swollen lymph nodes can be seen in a CT scan or a PET CT scan. Making a diagnosis of Sézary syndrome can be very difficult because the skin lesions that you see can be very aspecific. So patients can have a redness that is quite similar to the redness that you see in an eczema or psoriasis or in a drug reaction. And so that in this instance, the type of skin lesions, the erythroderma, does not give you much information on the specific diagnosis. Unfortunately, the skin biopsies often are disappointing as well, because you do see that the skin is affected. So you do see some enlarged vessels with some changes in your keratinocytes, but you do not, it's very difficult to recognize the tumor cells. The place that is best suited to diagnose Sézary syndrome is the blood. And for that reason, it's we often check the blood, and first looking at T cell clonality, so this is a molecular marker, so you could say, but then looking at the atypical T cells that can be recognized because they have different proteins on their cell membrane, and this can be investigated using flow cytometry. This has become the most important diagnostic tool for patients that present with a redness and itchy skin. These patients could be a Sézary syndrome, and then you will analyze the blood using flow cytometry. But nevertheless, this is quite complicated and is something that is really is clustered or is performed in centers of expertise. After the diagnosis, of course, we would like to give patients a very good treatment, and some things are the same as in mycosis fungoides. So again, this is a sort of light therapy. This is the local steroids, so with an ointment with corticosteroids. Again, the mucin, the chlormetine, can be used, but you can imagine using these type of therapies, we are only treating the skin. And as we just discussed, the tumor cells are very much present in the blood as well, and this is often not sufficient. So you will need additional treatments. And additional treatments can be found in using interferon and bexarotene or extracorporeal photopheresis. These are still quite mild treatments, but often we have to, if the tumor cells, the number of tumor cells become more, we have to use these type of chemotherapy, so methotrexate, leukeran, fluorodisine. These are all monotherapy, so you're just giving one type of chemotherapy. Again, well, this is rarely used anymore, but what gives us a lot of confidence is the new antibodies. So antibodies against CD52, but in particular against CD30 and CCR4 can be very, very helpful. And using these antibodies and more advanced radiotherapy protocols, we are now in a better position to treat patients with allogenic stem cell transplantations. And with that treatment, you can, although it's still difficult and it does have risks, and people can also, because of the treatment, become so immunosuppressive that they die. This is a treatment that can also be helpful, and we can cure patients with that. And with that, I think I've come to the end of my slides. I hope they were somewhat informative, and we will now quickly go to Mieke, who will present her view on all this, and I hope I've sort of set the stage for her to tell us her story.
Maarten, thanks for your presentation, and I will proceed with my patient journey. In a nutshell, my name is Mieke de Leeuw. I'm 69 years old, married to Ton. I have 4 children, 2 of our own and 2 married into the family. And one is watching this webinar. Welcome, Christy. And 4 grandchildren. I'm retired and live in Venlo. Our Lymphoma Foundation, Stichting Huid Lymfoom, is a patient organization for patients with a form of cutaneous lymphoma. My husband, Ton, is also a volunteer in our foundation since 2018. Today, he is helping me during this webinar with the understanding of the questions, because his English is a bit better than mine. And this is Ton. And we have, of course, lots of questions for Maarten Vermeer and Susan. The diagnosis of cutaneous lymphoma can turn your life upside down. The diagnosis, treatments, and the time afterwards raise many questions. In this webinar, I tell about how this went in my life. The start. The discovery of a bump above my collarbone in 2017 set off a lengthy testing trajectory. But it began before that, 10 years of skin conditions that got worse and worse, and that were hard to live with. Numerous wrong diagnoses and doctors saying, it's not that bad, or you'll have to learn to live with it. I tried. My skin was red, itching, burning, and it was very difficult to sleep at night with these problems. And during the day, it was difficult to stay concentrated on my job. On the slide shown, you can see how my cancer has progressed so far and what the value of our foundation and other patient organizations has been to me over the last few years. I explained for each year what it has meant for me. What in 2018, there was a diagnosis, therapy, and my question, am I going to die? Rather not. But after months of waiting, in 2018, finally a diagnosis arrived: two rare non-Hodgkin cancers, mantle cell lymphoma and Sézary syndrome, both incurable. For Sézary syndrome, 5-year survival rate of 23% in 2018. The MCL turned out to be indolent. The first year after the diagnosis, you are mainly concerned with yourself. If you are unlucky, are you going to get very sick or not? What does the survival rate mean? Some fellow sufferers are going to clean up their house, done with their lives. Unfortunately, a diagnosis that comes too late means more severe treatment and worse prospects, and therefore a worse 5-year survival chance. Suddenly, I also had to deal with the fragility of life. My story is also the story and the fate of many, many patients with rare forms of cancer. You need family and friends to deal with CTCL in the first year. What was the importance for myself to get in touch with fellow sufferers or a patient foundation where I could join? The answer in 2018 was to get information, to get information, to get information, more information, more information. I have a question for Maarten and Susan. What advice can you give patients to deal with the information found and with the survival rates?
Well, I think that's a really great question. I'll jump in here quickly. And we actually had a question in the chat that maybe we can talk a little bit about with regards to your question too on the survival rates. I think that finding other patients and connecting to good sources of information. I know we hear often that people after they've gotten a diagnosis go out and do a Google search, which I think is often the most frightening thing to do because so many other things come up. And if you are just diagnosed, you have no idea anything about the disease. So you can't sift through what might be good information or where you fit. I think as Professor Vermeer outlined early, the disease is different and the different iterations are different. And so depending upon your specific diagnosis really then impacts what therapies are appropriate and how your disease may or may not progress. So I'm delighted and so thrilled that you were able to start your organization there in the Netherlands. And I hope that we'll be able to do a lot more in other countries to connect people to other patients locally, because I personally feel that's so important. When I was first diagnosed in 1991, there really wasn't even any internet. So I was handed a scientific paper and I had no idea. So the resources that we have today, I think are wonderful. I think the challenge now is how do we channel that to the individual where they are in their journey and help support them along the way. And I think this webinar is a beautiful example of that and making this kind of really good information available to folks and connecting everybody to the right places.
Thank you, Susan. Thank you.
Martin, did you have anything?
No, I couldn't have said it any better. I might have said it much worse actually. It's what you are saying is very essential. So making the right diagnosis. I hope I'm sharing my screen now.
Yes.
Yeah. Okay. So making the right diagnosis is essential, but then after you've made the right diagnosis, it's essential to also find the define the right stage. So this is a patient with mycosis fungoides. This is also a patient with mycosis fungoides.
Yeah.
This patient has very limited disease, only these scaly lesions on the buttocks. This patient has a 10-year disease-specific survival of 97%. So actually his chances of survival are the same as someone of the same age and gender. This patient is poorer off because now tumors have developed. It's the same diagnosis, but it's a different stage. So this is mycosis fungoides tumor stage. For this patient, the 10-year disease survival is around 40%. So 60% of patients will die in the next 10 years.
Martin, we had a question in the chat that might be appropriate to address now. The question was asked about the survival rates. So for 10 years for mycosis fungoides, as you said, I think it gets a little confusing sometimes when we talk about survival rates because we don't always have all of the data from all of the patients. And when maybe you can talk a little bit about, they ask, is this considered terminal, especially if you're in that early stage with 97%? I think it gets a little confusing sometimes.
Yeah, I agree. That's why I thought I hope that this would be helpful. It does get confusing, and so how do you interpret these percentages? As I try to point out, it's important to know your diagnosis and it's important to know your state. So let's say you're this patient, you know your diagnosis is mycosis fungoides, and you know now that your stage is T1. If then you know that your survival is 97%, which means that after 10 years time, 97% of virtually all people with these diseases are still alive. It's only only 3% of patients will have died. Actually, this is very close or very similar to the normal population. For these patients that have more extensive disease and more bigger tumors, bulky tumors, now it's more difficult, and we now know that if in patients that have these type of lesions, in 10 years time, 40%, so 4 in 10 will still be alive, and 6 of these 10 people will have died because of their disease. And I should add to this that these are numbers that are based on a large number of patients, and this has been these data are not out for such a long time. We only know this now for around 20 years, and it's really because we have big databases where we look at all the survival of all the patients that we see, not only in the Netherlands but also in other countries. And because we have these big databases and we've been following these patients for a very long time, we now know that we can tell this specific story. It's still the case that for an individual patient, you cannot say, oh, now I know it, my survival percentage is 40%. This is not true because these numbers are still based on all the patients that have developed tumors. And it might be that in a particular patient that is in excellent condition, only has one small tumor, that the survival prognosis for that particular patient is still much better. And I think, yeah.
Martin, thank you for this information. This is for everything very important to know. There are many questions about that. Hoe heet dat, de onderdeel? I go further with my story. Is that okay?
Yes, of course.
Okay. In 2019, therapy by prednisone and chlorambucil, brand name Lucaran, loneliness. The second year after the diagnosis and the start of the systemic treatment, I got chemo pills and prednisone was scary. Would it all work? Patients from US and Australia told me no one uses prednisone. Some told me it's not a good drug for you. And if not, then what? I didn't know anyone in the same situation, anyone with the same medication. Still no one in 2021. And there was nobody with Sézary syndrome to talk to. It was very lonely. I discovered the Cutaneous Lymphoma Foundation, and I discovered Susan at the Facebook group Sézary syndrome. The Facebook group was very helpful. I read reports from America and Australia that stated how fellow sufferers dealt with their illness. There were many fellow sufferers who had a good quality life for years after diagnosis. I also searched the entire internet because there were no leaflets for Sézary syndrome in 2019, and also not for my second cancer. I read in the ESMO guidelines in 2018, long-time treatment with a combination of low-dose chlorambucil and prednisone is often effective in controlling the disease SS, but is unlikely to yield complete responses. Perhaps there are more patients with this treatment in Europe. Martin, I have another question for you. In your presentation, you mentioned that there is a limit to radiotherapy treatment. Is there a limit to systemic chemotherapy? A limit to brentuximab, MOGA treatment? Can you tell us about that?
Yes. So all treatments that have effects always have side effects. That's always the case. Depending on the drug that you are working with, you will have different side effects. For instance, brentuximab, the anti-CD30 antibody, will have as a side effect neuropathy. It will affect your nerves. And this is a so-called rate-limiting side effect. So you can treat patients with brentuximab up to a certain point. Then the toxicity to the neural system becomes so much that you have to stop this treatment. Very similar, adriamycin, which is one of the drugs within the CHOP regime, is cardiotoxic. So it will always be toxic for your heart muscles. And this is also cumulative. So at a certain point, you have to stop using this drug. How strong you are, it doesn't matter. At a certain point, you have to stop. For other drugs, the side effects are different. Prednisone, often considered a very old-fashioned drug, which is true, it's been around for a long time. The principal side effects that we are concerned with is immunosuppression. But this is not cumulative. This is just, this more or less stays the same. So, as I try to answer your question as good as I can, different drugs will have different side effects. Some effects will be cumulative and some effects will be not cumulative. Again, depending on very much depending on the patient and the clinical situation you have to choose between different drugs. Radiotherapy, for instance, I forgot that one. Radiotherapy also has cumulative toxicity. So if you have given more than 60, 70 gray is the unit for radiotherapy, more than 70 gray, then you have to stop giving radiotherapy.
Thank you. Thank you. Yeah, I proceed. For rare forms of cancer, there's no standard care trajectory, and there are no nurse specialists like there are, for example, for breast cancer. I was lucky that I had a lot of trust in my super friendly and competent specialist at the Radboud University Medical Center in Nijmegen. Trust turned out to be a keyword. And the fact that I still work with the same specialists all the years, unlike many others who are going through the same process. But beyond the medical side, it's also about a high quality life. I had questions about my volunteering work, sports, yoga, walking, cycling, nutrition, skincare. I wanted my old life back so badly. My experience in 2019 was that you don't get any help with this part, but that you have to figure it out all on your own. And what was the importance for myself to get in touch with fellow sufferers and the Patient Foundation in 2019 was to get information, to share, to get information, to share, more information, more share. I have a question for Susan. Susan, what support can CLF offer to foundations in Europe?
Yeah, well, and I think this is the first step in that direction, right? As a small rare disease community, you know, there's not enough of us globally to really have those big patient organizations in every country. But I think what makes sense and what we can do going forward and what we've begun here as well is to collaborate with those organizations in other countries, whether it's your organization that's specifically connecting and serving patients with cutaneous lymphoma, or other organizations that are supporting patients with all different kinds of lymphomas, but are in individual countries. So for example, Guy Bouguet leads the French lymphoma group. He's been engaged with us to deliver information to patients that he connects with in France, and we collaborate and send information so that he doesn't have to find it or dig it up or reinvent it. And this is a collaborative process that I really am excited about growing and expanding, because there's, you know, we can provide information, and you as the individual organization or a group of people in country, we can work together, right, to be able to bring the best information into the country that makes sense and is aligned with the specialists in the country, the treatments that are available in the country, and so forth and so on. So it's, to me, this is such a great start to really beginning to pull together our global patient community and then deliver into the countries.
Susan, thank you. Thank you for your answer. I'm proud that in the past years, our foundation has developed, for example, a beautiful website, a Facebook group, extensive information options about the 19 different types of cutaneous lymphoma, and 4 newsletters a year. In addition to LUMC, we have a lot of help from the Rare Cancers platform, in Dutch, Platform Zeldzame Kankers of the NFK. They gave our foundation a huge boost, without which we would not have been there yet. I have a question for Maarten. Due to COVID, the Patient Day in 2020 could unfortunately not take place. In 2022, the National Patient Day will be organized live again. Maarten, is that correct? And can you tell us something about this?
You're correct. So we organized the first 2 patient days in the LUMC, and the last time I already said that the next time we will be happy to organize it again. And this offer still stands for 2022. As you know, the first 2 days were organized by the LUMC. We made the program, and we this time asked the Stichting Huidlymfoom that they are now in the lead to make the program. And of course, we will be very happy to collaborate and think about speakers, etc. But we think it's this could be a good moment to put the patient organization in the lead here to to tell us really what you would like to organize.
Thank you. Thank you. I proceed to 2020 therapy, unexpected side effects, mental problems. The third year 2020 started out well in the first week, but after that it turned into a year full of side effects from the medication mentioned in this webinar. And then came COVID. For the first time in my life, I asked the help of a psychologist from the Helen Downing Institute in Nijmegen, who actually bungled at the very bottom of my list of resources, because there's a feeling of shame when you can't cope by yourself and need outside help. Furthermore, my greatest fear was that the cancer would be visible on the outside, shown by the pictures. In 2020, I wanted information, I wanted share to inform and advocacy. I have a question for Maarten. In the Netherlands, the vision has been developed about the role of expert care for people with cancer. There are 15 criteria established by the joint patient organizations. A group from our foundation is in consultation with you, with the LUMC, to focus this vision on the way in which the expert hospital deals with patients. Example of a criterion: better care for patients by appointing specialist nurses who act as a point of contact and who have sufficient knowledge and time. Maarten, what is your expert hospital, the LUMC, doing on this topic?
At the LUMC, we as a hospital want to have a comprehensive cancer center, and so this is not only the dermatology department, also the department of colon, carcinoma, etc., etc. And we are appointing at this moment people that are not the doctors themselves, but are the specialty nurses that can be consulted by telephone, etc., with specific questions that people have. This is one thing that we hope that will be organized, or we are busy with already for some time. And at the same time, unfortunately, we have at this moment 15 million euro budget cut. So that's 6% of our budget, and we are also asked to produce 15% more than we have produced in the years before, and at the same time we have the restrictions put on us by COVID. So it's not that. So the short answer to your question is that at the moment I do not have a nurse that can answer your questions 24 hours a day. It's not that I do not want it, but it's the question that we have difficulty finding the financial resources to do so. Having said that, what we have done, we have mevrouw Olja Blok-Sumanovic, who is a contact point for all the patients, and we have a dedicated mail address where patients can send their questions to, and the mail address and the all the efforts from Olja combined are directed at trying to answer all the questions that patients have as quickly as we can.
Thank you. Thank you. Yes, I have another difficult question for Susan. Where is Susan? A 2020 study found that women suffer more than men from the appearance of CTCL on the skin. What can our foundation do about this? What can we do about this?
Yeah, that's a really tough question. I think one important thing is being able to capture that kind of data across a large number of patients, and that's where being a part of the Lymphoma Coalition comes in, because we've been able to gather some of that quality of life patient experience data specific to cutaneous lymphoma, which, to your point, then raises these kinds of issues to the surface, where then I think we can collaborate together amongst the patient organizations, but also with the clinicians, to say this is an issue that we need to find a way to address. And I think finding other resources like the Helen Dowling Institute and other groups that have coped or have programs that we can either tap into or take and modify to help our patients, and then to be able to disseminate and share around the world, that these tools and connections and programs are available. I think that's, you know, as Martin said, it's a long project. There's a lot of pieces and parts, but I think this kind of thing is really important, and we're beginning to be able to, as a small rare patient community, if we can all come together and collaborate with our clinical, the clinicians in the field, and be able to then cooperate, pull all of our resources and put these kinds of initiatives together, and then send them back out into the different countries. I think that's a big vision, right? We won't do it tomorrow, but I think even just having the conversation is really important, and figuring out what we can do short term and what might be good long term.
Susan, thank you. That's our dream.
Yes, that's our dream, exactly.
I proceed with 2021 therapy. I have now started the 4th year after the diagnosis. Is the treatment providing what I want? Yes, it actually does, because the treatment plan still works well, and the side effects are manageable or can be solved. I get more and more optimistic about my former pessimistic prospects. For me, it means that after 3 years, my perspective of time, my goals, and my motivations have changed. I put more emphasis on living by my values, how natural but special family and friendship are. Focusing my volunteering like stimulating scientific research from the perspective of patients, because research is also given too little attention for rare forms of cancer. My lessons after living with a rare form of cancer for 3 years: accept what can't be changed, adapt and move on. And very important, remain in charge regarding my disease. Now I know the meaning of shared decision making. In 2021, I want information, share, inform, advocacy. An example of what a patient organization can do in the Netherlands is the following example. New targeted therapies against all types of cancer have improved the prognosis and thus the quality of life of cancer patients. However, rare cancers, including CTCL, are lagging behind. Much research is still needed to improve this. The LEMC has started a new study with 13 other European centers of the Cutaneous Lymphoma Working Group and Euroflow. The LEMC has requested our foundation to look at their subsidy application. Our foundation then wrote a letter of support for this project. The foundation has also looked closely at the patient information letter.
Oh, thank you. Oh,
The patient.
Let me write it. Oh, I'm going to the shore. That's why I'm getting ready.
Please mute.
The patient group finds the relevance of the research exceptionally high, and the letter of support is an indirect contribution to the quality of life for future patients through better detection of cells in the blood of patients during diagnosis, staging, and treatment. Our foundation will also serve as a platform for sharing the final results with our patient group. Maarten, what is the added value for the researchers to involve a patient organization in a research project? And for Susan, is this also the case in the USA?
I think there's an enormous advantage of involving patients in your research project. This is actually a rather recent development, but now the Dutch Cancer Foundation and also other grant-giving bodies, they ask you to write a part that explains your research to patients, and it very much encourages the involvement with patient organizations to establish a research agenda, because you can study many things, but it's in the end what we must study is are those things that are most important for clinical care. So it makes sense and to involve patients in a very early stage of the design and development of your research. And I'm very grateful for all the support that I receive, not only for this particular study that you mentioned, but also for other studies, are very much supported by the Stichting Huidlymfoom, and also apart from Stichting Huidlymfoom, individual patients, when explained in a good way why we would like to take additional blood or take even an additional biopsy, and nearly always patients are very willing to collaborate and to provide blood, even if they know that the answer that will come from this research, they will not benefit personally from this, but it will help progress, and I'm absolutely sure it will help us develop better diagnostics, so we will shorten this horrible diagnostic delay where people do not know what they have, and it will help us to improve treatments and maybe cure patients as well.
Thank you. Susan?
Sorry, I got tied up doing the chat.
Okay.
Yes, but I think that's, you know, one of the challenges, but what we can all do together is provide that kind of education, like Martin was saying. Once we can explain to the individual patients what it means to provide not only their physical samples of the disease, right, but also their experience. And that kind of collaborative effort is going on behind the scenes. And there's a lot of work that's happening to both educate the patient community about research and what's happening and what's moving forward, but also to connect the dots between the patient experience and the clinical practice and what's important. And there's what I will also say is in my engagement with all the clinicians around the globe, they are so passionate about the patient experience, not just treating the disease, which is of course very important, but how can we all work together to impact the individual patient's experience as they're living with the disease and going through treatments, and how can we do this better? And one of the important things is to collect that kind of data from all of us so that we can then go through it and understand where the big issues are, and then come together as the patient community and the clinical community to come up with some better ways or newer ways to address those things. And that's happening, and there's connections. It's a lot of work and complicated, but I think we're making great progress.
Yeah, thank you, Susan. Thank you, Susan. Education is important in order to be able to assess these types of studies, and also to be able to carry out other activities relevant to patients. Training is required. And in the Netherlands, this is offered free of charge by professionals to patient groups. And that's very bijzonder. Excellent.
Special.
It's very special, very special. The next slide shows which organizations work together and are important for our foundation. Now, everybody can read this, and then comes my last slide. Life is like riding a bike. Just keep moving and support each other in the meantime. And that's the end of my story. Thank you, Susan. Thank you, Maarten.
Great, thank you. That was really wonderful. Thank you for being so courageous and all the work that you put into putting this together and sharing your story. And I think it's so inspiring, and hopefully everyone else will be able to take a lot away from this. So I know we have run a little bit over, but I want to go to some of the questions in the chat, if that's okay. And if we certainly understand. Martin, are you able to continue for a little bit to answer some questions? Okay, very great. We talked a little bit about the survival rates. Question about, does stress exacerbate either the disease or the symptoms? Any thoughts?
I think that I'll answer this very shortly, but I think Mika will be in a better position to answer this maybe, because I think from what I observe or what people tell me is that especially if you have a very itchy skin condition, if you're stressed for whatever reason, this will sort of amplify, it will make it much worse. If you are in a very well relaxed situation, then a little bit of itch is something you can handle. But if you're very stressed, it can be horrible, of course. It's not that stress in itself is a risk factor for cutaneous lymphoma. In fact, we do not know what risk factors for cutaneous lymphoma are. It's a very rare disease, and it's not that it's always found in people that are very, very stressed.
In the first 10 years before the diagnosis, I didn't know what was going on. I don't know, our stress makes it worse. But nowadays, I pay attention to that process. And for me, I guess it's getting worse when I'm stressed. Yes, for me, but I don't know for other patients.
Yeah, I have heard that similarly. And I think it just exacerbates some of the symptoms and the worries and concerns and things of that nature. So I think we don't have good data. Maybe that's some data that we should be capturing at some point, right? So we can find some potential remedies. But I think things that people can do to try to reduce their stress will be helpful, just in my opinion. We have another question here. I'm going to try to paraphrase a little bit. A patient with folliculotropic mycosis fungoides, which is a rarer subtype. He's German, but they live in Malaysia, and the doctors say that this is a typical Caucasian cancer, and they don't have much experience with it. Her husband had a small patch on his abdomen, and it was excised, but 2 months later it reappeared, and they performed radiation, and then the patch appeared again, and they confirmed it as MF. They're not sure what to do, and what would you recommend as treatment now? And do you know a treatment center or specialist in that part of the world? I think that's one of our biggest challenges, right? Connecting clinicians in various parts of the world with experts that treat the disease to be able to share that kind of knowledge. Martin, I don't know if you have any thoughts. My thinking is to have their physician reach out perhaps to the International Society of Cutaneous Lymphomas.
I think that would be an excellent idea, because I'm actually very happy for this particular chat, because it very, very nicely shows you what the problem is. So I cannot now say, oh, this is what you should do, and it's definitely this, because first we'd like to have a firm diagnosis. You would like to have a good biopsy or a small excision that you can look under the microscope. You would have at least good clinical pictures, and then by combining them, you can make the correct diagnosis. And that really has to be done in an expert center. So one way or the other, we have to connect these people with someone, preferably in their neighborhood, that can help them. But I do not know a clinician in Malaysia, but maybe through the ISCL, we can find someone in the close by.
Yeah, and I would say if you like, you can always, I'll put my email in the chat, and please feel free to send me an email and I can help coordinate any connections with the international societies and try to connect your physicians and whomever with the international, maybe somebody that is close by or appropriate. And
if you run into trouble or if it doesn't work out, you can always mail with me, and I'll try to help.
Great, thank you. I think that's why it's so important for everybody to be connected, right? So we can help support everyone no matter where they live, which gets then to be a little bit challenging. Let's see, I'm gonna paraphrase here. When the diagnosis for MF is early stage and you get treatment, is it possible that the MF will not progress? Or does it not, or does it progress? And if you can progress it, is it very important to get a diagnosis in the early stage? So.
That's an excellent question, actually. And
Anjali, I think if hopefully I paraphrased okay, yes? Okay.
Yeah, I think I understand the question. Let's say someone just got the diagnosis mycosis fungoides and the skin lesion is very small, 1 centimeter big, and we would excise it, so it's completely gone. Could it be that it doesn't reoccur? And the answer is yes. So we do have some patients with very, very limited disease. If you give them a very aggressive treatment, mostly radiotherapy, then there is a chance that it will not recur again. Now, if you have the pictures that I showed you, it's clearly not possible to excise everything. You could then ask, well, if you treat that patient aggressively, let's say with radiotherapy for the complete buttocks, would that change the clinical course for that patient? Probably not. And why is that so? I think that's the case because there's an old trial, it has never been repeated, where they treated patients with limited mycosis fungoides, so only patches and plaques, with very intensive chemotherapy, and it didn't make any difference. So probably if the disease is a little bit more than just that 1 centimeter, it's already on a certain course, and you cannot change it by giving very intensive treatment. You have to treat those lesions that are there. You always have to give a sort of adjusted response.
Right, and so many of people with mycosis fungoides, early stage, their disease never progresses, but it requires treatment. So it may never move past the early stage, but it is important to treat it and then also to pay attention to see if anything changes. But many people just stay right where they are, unlike other cancers where, there is a typical progression if a treatment doesn't work. And so we're an odd group. We don't fit into a lot of the standard kinds of boxes here. Hopefully that answered your question. Okay, let's see. Someone shared that the average number of cutaneous biopsies are 5 before you arrive at the diagnosis of MF in patch stage. That's a tricky question too, right, Martin? Because it all depends on the biopsy itself and how many, when you showed that picture of the histology, how many of those cancerous cells are actually captured in that little piece of tissue that gets taken. So sometimes you have to take multiple biopsies in order to make sure you get enough of those cells that are elusive, especially in early stage disease.
True.
Right? So sometimes 5, sometimes more, sometimes less.
Yeah.
Right? It just kind of depends.
I think it's one of the areas where we want to improve in the upcoming years. And ideally, you would have a test that if you would have a biopsy, you would do that test and you would detect if it's mycosis fungoides, yes or no. And at the moment, this is not the case. So to make a diagnosis, it very much depends on the knowledge of the pathologist. but the general pathologist will only see an MF slide once every 5 years. So it's very difficult to get experience in this. So, but in these expert centers, we see around, I would say 10, 15 new cases every week.
Right.
So then you get, your knowledge accumulates and you get better and better and better. But even then you are very much dependent on the biopsy that was taken. If someone takes a biopsy from a red skin that does not contain tumor cells, you cannot make the diagnosis. And that's where sometimes we have patients, or actually quite regularly we have patients that we look at the biopsy and say, well, this could be mycosis fungoides. The patient visits our clinic, we take an additional biopsy, and then in that second biopsy that we take at our clinic, we see the tumor cells very clearly. And it's not that we are much better in performing a biopsy, but we are much better in deciding what is the most informative skin lesion.
Right.
And then the
Right.
interpretation.
Right, which I think is why the work that EuroBloodNet is doing with the reference centers and creating the new, and Martin, you know better than I, a group of specialists that are able then to work with non-specialists in certain countries from certain centers to help with diagnosis and recommendations for appropriate treatments and so forth, which we really never had before, and is a wonderful movement in the right direction to make sure that all patients, no matter where they live, are able to get the best treatment and the best the diagnostics, because that isn't available at every center, and you need that kind of clinical expertise to be able to read and have the tools available as well. I think that's our questions, although we did have a nice little, I don't know if you saw it in the chat, Mickey, but your daughter says, well done, Mom. I'm so proud of you. And I agree. I
Thank you.
agree. I think that that is all we have today. Thank you very much. Thank you everyone for joining us. Thank you for Martin and Miki staying with us to answer some of the questions.